Good afternoon. I'd like to call to order the Tacoma-Pierce County Board of Health in study session for April 15th, 2026. The time is 3:02 according to my computer in front of me. Can the clerk please call the roll?
Board Chair Hitchin.
I am here.
Vice Chair Bushnell.
Present.
Board Member Herrera.
Excused.
Board Member Mello. Board Member Olson.
Here.
Board Member, Ryasich.
Here.
Board Member Sadalge.
Here.
Board Member Yambe.
I
Alternate
am
Board
here.
Member Cook. Alternate Board Member Ayala.
Here.
Thank you. Alternate Board Member Diaz. And alternate Board Member Merrick. Thank you.
Thank you. And I have Board Member Herrera online. And Board Member Yambe. I just want to make sure because thank you all for joining us this afternoon. During our study session this afternoon, we have 2 items of information on our agenda. Are there any objections to our agendas? Otherwise, we are going to jump right into Black Infant Health, Black Maternal Health Week. And we've got Emily Chandler to brief us on this with some potential guests.
Good afternoon, Chair Hitchin, Vice Chair Bushnell, and members of the board. I'm Emily Chandler. I'm the supervisor of the Black Infant Health Program. And thank you for allowing us time to share about our program and Black Maternal Health Week. All right, so today I will be providing some information about Black Maternal Health Week and outlining where our work fits into the strategic plan. I'll provide some infant mortality data and also provide an overview of our program and how it connects to Black Maternal Health Week. And I will talk about some program outcomes and highlight a vital part of our program that allows us to provide behavioral health services for our clients. And then later, I will introduce you to someone who is very deeply connected to our program, and her story really is very powerful and reflects the heart of our work, uplifting and elevating community voice and leadership. And then you'll get to meet the other members of my team, and we'll close with kind of an open discussion and reflection. Okay, so this is the 10th anniversary of Black Maternal Health Week, which is a week-long campaign founded and led by Black Mamas Matter Alliance to advance Black-led solutions to address maternal health inequities. So we celebrate every year from April 11th through the 17th, and it's a time to build awareness and advocate for the elimination of maternal mortality globally. And this year, the theme is Rooted in Justice and Joy. So this theme really acknowledges the systemic injustices that continue to impact Black births, while also honoring the resilience and leadership of Black birthing people. It reminds us that this work is not only about preventing loss, but about building systems where families can truly thrive. So today we're going to explore both what justice requires and what joy makes possible. So as a part of our strategic plan, the health department is focused on the health outcomes of Black, Indigenous, and other parents and children of color by strengthening and expanding our maternal child health programs, such as Black Infant Health. So why is this work important? Well, in Pierce County, Black infants and mothers die at about 2.5 times the rate of their white counterparts and at greater rates than what is observed in the state on average. And these disparities persist even when controlling for social economic factors. So Black college-educated women experience higher rates of infant mortality than white women who have dropped out of high school. So you can also see clearly here on this graph that our American Indian, Alaska Native, and Pacific Islander communities also experience high rates of infant mortality, though these numbers are small, which creates substantial variation. But our broader maternal child health work involves programs that serve all communities like Nurse Family Partnership, our maternal child outreach team, and our family resource centers. So this graph shows the variety of trajectories of infant mortality in Pierce County by race and ethnicity from 2013 to 2024. And as you can see, some have low rates and some have very variable rates based on small numbers. But on the next slide, you can see that the African American population is the only large population in Pierce County to consistently have high rates of infant mortality over a long period of time. Also want to highlight that 2024 had the lowest mortality rate of the Black population since 2009, although still very high. So the Black Infant Health Program is a nurse-led community health worker model that provides ongoing individual and group-based services to any Black or African American parent, including those who identify as mixed race. And we provide services from pregnancy to 1 year postpartum. We aim to improve health outcomes for Black families by providing culturally aligned support and resources. So all of the services are provided by people with shared cultural identities. So we envision a community where Black families thrive and live healthy, joyful, and connected lives. And we aim to improve birth outcomes through advocacy, empowerment, and social supports. So what does client support actually look like? So as I mentioned, we have an individual and a group-based component of the program. So for the individual component, our community health workers provide monthly family-directed support to voluntarily enrolled clients through in-person visits, text, email, phone calls, and they provide emotional support, health promotion and education, care coordination, resource navigation, and as well as concrete supports like diapers, baby clothes, food, etc. Our nurse is the first point of contact with clients, and she completes an intake nursing assessment and also provides postpartum visits and is available for consult for emerging needs and consults both with clients and community health workers. And through a partnership with Open Arms Perinatal Services, we are able to provide or to connect 14 low-income families a year to full spectrum culturally aligned doula support. And then we also have been fortunate to be able to contract with a Black perinatal behavioral health specialist to provide direct support for our families. So we also, in our program, really emphasize social support and connection all throughout the program. So we offer monthly peer support groups for clients to connect with other families going through similar transitions. And twice a year, we host what we call Tiny Blessings celebrations that are to honor the families and the babies who have turned 1 and are graduating out of our program. And this cute picture is from one of those events. And then we also host a variety of other events throughout the year, like library events, wellness events, and summer celebrations. So I wanted to take a minute to connect the work with the theme and show how our work really aligns well with the Black Maternal Health Week theme of rooted in justice and joy. So we advance justice by reducing barriers to accessing services, reducing parental stress and isolation through relationship-based support, providing culturally responsive care and support, and by centering community voice through our community advisory board. And ultimately, our main goal is to cultivate joy. So we incorporate celebration and empowerment into all aspects of our programming. We provide affirming spaces for connection and healing, spaces for families to feel seen, heard, understood, and supported. And through social connection, we promote a sense of belonging in our community, and we aim to increase confidence in pregnancy and parenting as well. And ultimately, by empowering our community, we allow opportunities for leadership and growth. And here are some program outcomes and successes that we wanted to share. So we launched a redesign of our program at the very end of November 2023. So this data is representative from December 2023 through June of 2025, so about 18 months. And we had 69 enrolled clients during that time, and each of those clients received an average of 43 visits, or about 2 a month. And we had 25 babies were delivered, and 80% of clients reported breastfeeding their infants at some point. And of those, 72% were still breastfeeding as of the last contact with their community health worker. We also have 81% of clients graduated when their child turned 1, and 100% of clients who completed the client satisfaction survey said that they would recommend Black Infant Health to a friend if they needed similar services. Okay, so I also wanted to take a moment just to share some of the key findings from the 2025 Washington State Maternal Mortality Review Panel report. I specifically wanted to highlight that the pregnancy-related maternal mortality rates in Washington have increased from 19 to 30.5 deaths per 100,000 live births in just a few years. The panel also found that 82% of pregnancy-related deaths were preventable, and that behavioral health-related deaths accounted for nearly half of all of pregnancy-related deaths in 2021 and 2022. So a driving value of Black Infant Health is to ensure that our program is matching the needs of our community. So data like this, as well as data from our own program evaluation and direct reports from clients, really inform the elements that we incorporate into our program. And an example of this is the integration of behavioral health services into Black Infant Health. So in January of 2024, we were able to contract with Kyla Care Therapy, which is led by Lindsay Williams, a perinatal mental health therapist. She provides trainings for our community health workers on topics like perinatal mood and anxiety disorders, self-care, and boundary setting. And she also offers culturally relevant individual and group therapy to our enrolled clients. Our community health workers complete PHQ-9 depression screens with their clients, and we refer all clients with a positive score to Kyla Care for services. And since our contract began, she's completed 193 sessions with Black Infant Health clients. Additionally, to better meet the mental and emotional wellness needs of our clients, we've implemented various community-centered wellness events throughout the year, and we hosted 10 of those events since January 2025. And here you can see some examples of the types of events that we've hosted. Events range from library events with a local Black children's book author to postpartum and pregnancy wellness discussions, to summer and fall stroller walks, and our Tiny Blessings celebrations, just to name a few. And then here are some pictures from some of the various events. You can see our wellness walks up at the top, and down in the bottom right is from a library event. And then I wanted to highlight on the bottom left here that we typically have a lot of other vendors come and table at these events to just increase access to resources for our clients. I also wanted to share a client quote that I think really highlights the impact of these types of events. So in regards to one of our wellness events, she stated, the messages really resonated with me, and that being a mom can be stressful, and that it's okay to take time for yourself, and that your feelings are valid, and that taking care of a little human can be overwhelming. So we are really grateful to be able to incorporate this into our program. Okay, and now I am honored to introduce you to Cormisha Passmore, who began as a participant in Black Infant Health, and she joined our team as a contracted community health worker, and she will be joining our team as a full-time community health worker with the health department later this month.
Hello, everyone. It's so nice to meet you all. My name is Cormisha Passmore, and I am the community health worker in the BIH program. I'm truly grateful for the opportunity to speak with you all about my experiences and journey in the program. I joined BIH as a client shortly after the birth of my second child. My postpartum period was really challenging for me. I was balancing being a student, working full time, and raising now two children. And as you can imagine, that was pretty overwhelming. While talking with a home visit nurse about my struggles I was experiencing, she told me about the BIH program. That's how I joined as a client. It immediately caught my attention because I had never heard of a program that specifically supports Black mothers and their children. She told me about the lactation support, peer groups, and community events, and I realized that this was a great opportunity for me to connect with other Black mothers who might be experiencing some of the same challenges I was facing. We often hear the word support as a blanket term that many programs use, but what does that really mean? Support for you may look different for support for me. At BAH, the support I seeked was community. The program helped me realize that I didn't have to struggle alone and that there were people in my community who truly cared and wanted to see me succeed. That experience inspired me to become that source of support for other mothers, which is why I pursued a position within the program. Many Black and Brown mothers often feel like they have to carry the weight of caring for their children, supporting their families, and navigating societal pressures all on their own. What I love about BIH is that it challenges that idea. It reminds mothers that they are not alone and that there's a community that wants to see them and their children thrive. You may have heard that the theme is rooted in justice and joy. When I think about that, I picture a tree. It sounds kind of cheesy, but every strong tree begins with deep roots. Those roots represent the people in this program and in our communities who provide support and care and guidance. The mothers are the trunk of the tree, strong and steady. When the roots nourish the trunk, the tree can grow. From there, the branches and leaves grow, and that's where we see the fruit of the tree, our children. When the roots are strong and the trunk is supported, the entire tree can grow and flourish in the same way. When our community supports our Black and Brown mothers, and when our mothers receive the justice that they deserve, then the children can truly thrive. Thank you.
Thank you, Misha. Her story really reflects that when systems invest in the right supports, we don't just see better outcomes, but we see leadership, healing, and community growth. So thank you for sharing with us, Misha. Okay, so now I want to introduce you to the rest of my team.
Good afternoon, board members. My name is Amanda Jones, and I'm the Community Engagement Coordinator. I lead our peer support groups, our Community Advisory Board, and I share our work with the community. Thank you for having us today.
Good afternoon, members of the board. My name is Cassandra Witt, and I am a registered nurse with Black Infant Health. My role is to support families from pregnancy through the first year of life by bridging clinical care with community-based support. I develop and provide clear, practical health messaging for our community health workers to share with clients, ensuring families receive accessible and culturally relevant information. Through home visiting, I complete enrollment assessments and provide postpartum support while being available to monitor infant development milestones and throughout that critical first year. I'm also a certified child passenger safety technician, meaning I can offer car seat installation and fit checks to help keep infants safe on the road.
Good afternoon, members of the board. My name is Ratanya Oslin, and I am the Community Health Worker Coordinator. I work directly with our community health workers, supporting them as they support our families. Our community health workers right now that we currently have are Marge Blount, as you can see, Marquetta Ferguson, who is a newer hire, Cormisha Passmore, who will also be transitioning into our full-time community health worker position, Quilina Peterson, also a new hire, and Barbara Wright. Thank you for having us.
So we wanted to end with kind of a reflection discussion. As leaders and decision makers in our community, your perspective is an important part of this work. So keeping in mind the Black Maternal Health Week theme of rooted in justice and joy, where we're kind of envisioning justice as the foundation and joy as the outcome that we're working towards, what do you all think equitable care requires from systems like ours?
So thank you for raising the question and for the team doing the work. And I'm going to see what questions my colleagues have based on, or feedback based on this question. Executive or Board Member Mello?
Thank you, Chair. I do have a number of questions. It's a very exciting program to learn more about. So thank you for making sure this got in front of the board. Focusing first on the question you're prompting with the board. I guess what comes to my mind is making sure that we have staff and contractors that look like the community that we are trying to serve. And you've demonstrated that very clearly, that we have folks with lived experience and folks who look like the community that we are trying to serve. So for me, what equitable care would require from systems like ours is to making sure that we are investing in supporting the continuing education and professional development and hiring and training and supports of the workforce that we need so that we can have trusted folks in communities serving the targeted population that we're trying to address. So that's what comes to mind. When you're ready, Chair, I have a number of questions to further probe on this important program.
Okay, we'll start, we'll stay to the probe and leave the questions so we can help our community here figure out. So other comments on the question before us? Board Member Yambe.
Thank you, Madam Chair, and thanks for that presentation. I think equitable care requires from systems like ours. I think it's also coming into acknowledging that different communities have different relationships with our healthcare system and that we are entering at different points there. Like in our recognition of Black Wellness Week at the county yesterday, one of the things that I pointed out was that, we have, history and historic traumas and a deep mistrust, understandably, of some of the systems that we have for healthcare. And it looks different to different communities, and particularly the Black community has understandable traumas. And as we can see, that we are still wrestling with the issues of Black maternal infant mortality and all these other things that are, it's confirming suspicions and confirming long-standing trauma and needing that when all of us access care, that the people who are providing it, like the executive Mel said, not only look like us, but then have an awareness of where people are and being able to communicate not only culturally competently, but understanding why we have some of those places that we don't trust the system, and actually listening to us and not saying, oh, well, your people experience pain differently, or these suppositions that have been for lack of a better word, lies that have been perpetuated over hundreds of years. So that, and just being acknowledging that each of us are people and that we have different needs, and to be actually heard and listened to by the people who are trying to help. So those are my thoughts.
Thank you, Board Member Yambe. Any other Board Member Sadalge?
Thank you, Chair. When I think about a question like this, I usually think about the larger context of this idea that in a world in which we have like limited resources, certain groups are deemed the haves versus have-nots, and we systemically and historically have valued one over the other, right? So when I see, when I think about a question like what do we do to address it, I mean, one of the first is what you put in one of your first slides, which is just to have information that lets us know that it exists, and then to do a set of treatments that kind of understand what that differentiating factor is that's leading to those other kind of outcomes, right? And to come up with treatments that like identify that. So I like that I'm seeing that in this presentation. I also have a number of questions, so I'm going to kind of leave it at that because it will kind of grow from this statement.
Thank you.
I think if I can answer your question, what does equitable care require? My only question, I'm curious if some of the other groups identified, the American Indian, Alaska Native, and Pacific Islander, from a percentage standpoint, they're right there next to the Black numbers. But I'm curious, I don't know about overall populations of those groups within Pierce County. Maybe the Black population is just much higher than those others, so it makes sense to focus on that. But I don't know, I would just ask the question, is there an American Indian, Alaska Native group that's saying, hey, well, what about us? You have this Black infant health, but what about American Indian health? Or so I don't know, that would be the only, I think, trying to answer your question. So just curious about that.
Yeah. Yeah, so definitely the Black community in Pierce County is much larger than the other communities, but clearly there's still a disparity that exists, and that's something that also needs to be addressed. Our specialty, or subject matter expertise, obviously is within the Black community, so that's kind of, we've been growing and strengthening our program to make it fit what our community needs. But our goal would be to be able to have a model that could be replicated in other communities where they can take it and adapt it to what makes sense for their community needs. That would be that's our long-term goal, I think.
Thank you. And then I think I would add, and then I'm going to open this up for questions. For me, it would be that there wouldn't be a graph with disparities. I mean, I would love to just end all premature deaths of women for just the sake of reproducing. That's not something that's supposed to be a death sentence, but we have disparities for multiple populations, and I think they can't, the data speaks. More than half were preventable. We missed the boat with 50% of those people. They would still be here and be able to be a mom if their child survived. And if their child didn't survive, then we lost both people. And the harm done is irreversible. So I heard a teaser that we were going to go multiple questions. I'm going to just kind of go in the same order. So Board Member Mello.
Thank you, Chair Hitchin. Appreciate Board Member Olson's question. That was one of my questions. So thank you for asking it. And appreciate the thinking about how we can build to other communities that are experiencing disparities. My next question, and I'm happy for there to be follow-up in the future, especially on this one. I really appreciate on slide 4 how we always ground these conversations in our strategic plan. So thank you for having the discipline, all of the staff for having the discipline to continue to ground these discussions in our strategic plan. In this one, I appreciate measured, the strategic initiative about improving health outcomes, and the measure G, decreasing health inequities among BIPOC communities by the year 2029. To me, I raised this the last time we had a strategic plan update, and this is just a classic example. Throughout the plan, in several areas, we say we have a goal of a certain percentage or a certain amount by a date certain, a SMART goal. So in many instances in the plan, we do that. This is an example where we don't do that. We say we're going to decrease the inequities. That's great, but I can't help but ask, by how much? What is our goal? By how much? Realize you're not prepared to answer that question today, but I continue to raise that to my colleagues and to the senior staff, that it would be great to get consistency and have to have SMART goals with all of our measures. So I'll leave that one there because I suspect you're not prepared to answer that one. Do you know, my next question, do you know how the program is funded? Or maybe you have a friend in the audience if you don't know.
I do, but I don't know the exact amounts, which Andy probably does if you want that. But we get funding from a lot of different avenues. We get some funding from the Pierce County Behavioral Health Tax, which is actually what funds our contract with our mental health provider that I mentioned.
That was the answer I was looking for, but go ahead.
Great. Yes. yeah, we've been able to do a lot of really great stuff with that funding. And we also get funding from the city of Tacoma, and we get funding from the Balmer Group, a philanthropic organization, and the health or HCA and Department of Health, or Department of Health, yeah, and Healthcare Authority. And then we get FPHS, some money from FPHS also.
You're getting lots of thumbs up from
Is that
people in
right?
the background, so we
Great.
crowdsourced that. I like it.
Great to see the braided funds and the local dollars of our local behavioral health and therapeutic courts tax dollars that we invest here in a very equitable way to really focus on a really important challenge. So thanks for that. I think my last question is is around scale and scaling up. We got to meet the team. We got to meet contractors. It's great just to get a sense of our current operation, our current scale. Can you share with us, how do you think our current capacity is able to meet the current need and opportunity to make a difference here, to really bend that trend and meet our strategic plan goal? And what is needed to scale, if something more is needed to scale in order for us to truly meet our goal that we have for 2029?
Yeah, I don't know how candid I can be in response here, but I think that I mean, funding is always the big thing. Like we have our capacity, you know, is obviously limited by how many folks we have and how many clients we can take on a caseload at one time. Our, you know, dream goal, our dream, I don't know, just our dream, I guess, not a goal, would be to have more like full-time staff, like Cormisha is joining us as full-time, so that, because our full-time community health workers carry a caseload of like 30 to 40 clients versus our contractors carry 4 to 7, because it's, you know, they have other jobs and they're doing it on their off time. So it would really help increase our capacity if we could have more full-time staff, and just then frees up some more time for us to also do outreach and community engagement. I think getting getting our name out there more and everything, that's a big part of Amanda's role in our community engagement. We try to, you know, a lot of our referrals come from word of mouth, or my sister was in the program, et cetera. So some sort of like ad campaign or something, it would be something cool in the future to do. But we really, I think our focus right now, we're with the capacity we do have and the funding we do have, we're focused on trying to like build the strongest program that we can and show outcomes that are effective for our clients. So then we can bring that to funders and try to get more funding and build the model upward. I think that's it. Is there anything else? Yeah, staffing. We've had some, you know, staffing turnovers and things like that too, which always can cause a little riff in our client caseload and how many clients we're able to take. And so we're really grateful to have Misha coming on board now to get that back up. But I think, yeah, having more like full-time staff would be helpful with when there are staffing transitions too. I'm trying to think of anything else. Do you have anything?
I was just going to say, to add to that too, just the sustainability of the program and making sure that this program has the longevity that it needs to show the outcomes. Because one of the numbers that are harder to see in the short term is the maternal morbidity and the maternal mortality. It takes a long time to see the change in those numbers. And so the longer time that this program is around, the more I think the better the outcomes will be.
Okay. Yeah, I think that's a really, really fair point. And so we're really hoping to hone in on some of our outcomes that, like, we're on one of the slides I showed, looking at kind of the direct effects we're having with our clients in the short term, and then with the long-term goal of having an impact on the infant and maternal mortality rates. But like Retania said, that takes longer to see. But
Last question, Chair. Especially for those newer board members and committee members, tuning in to learn about this. Can you just give us a sense of when did the health department start this program? How new is it? And what's different from?
Yeah. So this program has been around since 2009 is when it started. It was founded by a Black public health nurse who worked in the Nurse Family Partnership program here, Leah Johnson. She just saw this need in the community and kind of took it upon herself to build this program. And but it was very underfunded for a long time. It was mostly volunteer based, and so their capacity was obviously very limited, and their ability to gather data was rather limited with that model. And so, I believe in when did I start here? 2022. I came on board, and we with the goal of kind of structurizing, that's not a word, the program and like creating some more structure around it, so that we could show outcomes and kind of build it up. So that's when we got funding from the Balmer Group in 2023 to really like test a pilot model that was to show effectiveness. And so we did a lot of community assessments. We did interviews with past clients and surveys with the greater Black birthing community in Pierce County, and tried to identify components of the program that were missing or that we should grow. And so that kind of helped inform our work, as well as like literature reviews and looking at other community health worker models. So then we were able to kind of come up with the model that we have now. And we really intended this whole pilot period to be really iterative, and we are, we're doing evaluation every year, but we also are, like, I think I mentioned this on the behavioral health piece, but we're trying to take what the community is telling us and adapt it as best fits, so that we can be really responsive to what's needed in the community and create like the strongest model that we can, so that we can go forward and scale up, hopefully. But yeah, so in, I think 2000, well, when did you said 2019? We grew a little bit more in 2019 that Tanya started then on this team and had a few more staff. And then obviously COVID kind of disrupted service delivery a bit. And then I came on board afterwards, and that's really when we kind of were able to get more funding and put a more focus on this program and build it up.
Thank you. Thank you so very much. Thank you, Chair.
Thank you. Additional questions from this side of the table?
Thank you. At least two of the questions were Board Member Olson and Board Member Mello. So couple of questions I have. Slide 5. I do have a black and white copy, but I believe if I look at slide 5, it looks like Pierce County has worse rates across the board. And are there reasons for that you're aware of, or someone else over here can explain to me?
Maybe.
I mean, this is really startling for me, and I'm not gonna lie, this actually hits me a lot more personally because I have an 8-month-old, right? So a year ago, when you guys did this, I didn't have a baby that I could like think about dying, right? And to see that across the board it's worse, I would love to know if there's any color around why Pierce County just across the board has worse outcomes.
Yeah, it definitely is. I mean, okay. I was gonna say, I don't have any like specific answers, but I can make speculation kind of why we think. Is that what you were gonna say? Okay. Yeah, we don't have any like hard data about why it is, but I think, we see kind of like a disjointed healthcare system in some ways in Pierce County with our different health systems, and also just
So some of it is like comorbidities, and some of it is confounded by the COVID factor. We do need to get back to you on some of the answers, because this needs to be stratified for extrapolating the things that happened during COVID. But we will definitely get back to you.
I mean, or if there's a way for me to help you advocate with some research program out there, if these are the, I would love to. One of my questions later on is what can I do to support advocacy as an elected official through different bodies on things? Because I don't think you're responsible for solving that entire chart. I'm not asking that. I just wanted to know if there was something that we've done. If not, maybe there's an opportunity for us to ask, hey, we're seeing this and we want help researching what is actually happening in this community.
So some of it is we have our infant mortality review, and we're looking at some of the through lines and what happens in those spaces. And then also in some of the hospital systems partnerships that we're working to develop. We're working to make sure that in those conversations and how do we develop the partnerships, that we start the preventative side, but then also in how we do education and information. There are some of those efforts that are happening in the spaces. We brought our new Strengthening Families Division Director, and we're building some of the practices, but it's in development right now as we speak. So there's more to come. But there's going to be some spaces for us to develop advocacy, and there's some spaces for us to be able to develop further partnerships that we're going to be working on.
Okay. I mean, because there might be a legitimate reason, right? I mean, we have Mary Bridge, and so maybe there's a higher rate just because there's a lot of kids getting treated over here, and the way we collect data is where they pass away. I don't know. I'm just kind of making it up. I'd love to know if there's a real, like, systemic issue and what I can do to help you. My next question, and this is a really startling statistic on slide 13, to see a 50% increase in mothers dying is effectively, is that just pandemic? Is there another underlying issue over here? Because that appears like a massive increase unless it was across the board.
Again, so if you look at the numbers that we have here, you see 21, 22. Some of it is what we saw during COVID. And again, like there's some things that we have to stratify the numbers for. But what we saw during COVID, the numbers in mothers that were affected were much higher. Now, some of this is anecdotally, some of the things that we saw in the numbers that were presented. But again, we have to do a thorough review, thorough research in order to be able to figure out what exactly are the indicators as to why the numbers look the way they look. I can't say definitively here specifically in this space, but these are some of the things that I found in how we were looking at numbers during that time frame. I would like to be able to do a further review and be able to get back to you and say, like, here's what we found, here's what we're looking at, what we can do and put into place, and how we do our responsive and build programming in those spaces. But yeah, it's something that we'd have to look at.
If there's, I think the board as a whole would consider if you needed board approval for anything. I'm sure we could have that conversation. The last set of questions is actually, can you help color in what does a community health worker do? Like just to kind of give me better context of, like a day in the life, if you can do that really fast. I was kind of trying to imagine the good work everyone does. You did a great job of introducing him, and I was like, I wonder what they do when they interact with people.
Yeah, I'm bringing Misha up too, because she'll have some firsthand experience, obviously. But so our community health workers do ideally 2 home visits a month, often less than that, depending on what the client wants. We, try to be really client driven and match the needs of the client. So
the clients are usually people who've given birth, or is it prior? Or
yeah, good question. So we people can join our program anytime from pregnancy to 1 year postpartum. So it's ideal if we get people early in pregnancy so we can do more of the health education and birth planning and things like that. But if their baby's 6 months, they can join the program for 6 months until their baby turns 1 and graduates. So we kind of have a variety of when folks enter the program. So like I said, Cassandra, she does our intake visit as a nurse and kind of does the whole nursing assessment and assesses what they're looking for and what areas they may need support on. And then that kind of helps us assign to a community health worker. And then they, are texting and calling and emailing clients often, resources, things like that, but they're meeting monthly with them, really there for emotional support as well as health education. They're an advocate for them if they can sometimes go to their doctor's appointments with them. and help them translate the information or just an advocate for them. And they help them with, all types of resources. So obviously our program is focused on maternal child health, but we look at the person holistically. So they'll look at, transportation, food insecurity, housing, anything like that, and try to get them connected to resources that can help.
Emily pretty much explained most of my job, but it's okay. I just feel like community health workers are just like that bridge and the gap between the client and the resources that are out in the community. So we come in and we try to bridge that gap by giving them those resources they need. Like support is different for everyone. So depending on what they're looking for or what kind of support system they have, like family support or community support, that's what we go out and we find and we bring it to the client in hopes that they will be able to use this support system once their baby is graduated from the program.
I'll add to in addition to connecting to resources, really helping through that process. Sometimes the applications can be cumbersome or you're not sure what documents you need. And so they can really help them flesh out that and try to get connected easily to resources and getting them connected to healthcare providers if they're not already. We kind of just look at the whole person and see what they need and try to find a resource or something that can help them.
So at least once a month, you actually meet with individuals.
Twice a month.
Oh, you try to do twice a month.
In-person meetings. Some clients may prefer that don't come to their home until they feel more comfortable. So like an online meeting or FaceTime call. Sorry. Or sometimes we'll meet at a park. So kind of just meeting like where they're at and where they feel most comfortable. So I try to see them at least twice a month, if not more, if I can.
Okay. No, that's wonderful. And so I'm gonna end with what I kind of mentioned before, as we, the power the group here has as elected officials is we have the ability to, whether it is within our purview to change a policy, we also have the ability to advocate on a state and even federal level for resources. So as you're doing this and growing this program, you're getting a lot of really good information out there on what's actually happening. And if you can help us inform what are ways we can actually advocate that might really make a difference. Maybe it's not something you guys control, but maybe there's another program or resource or set of funding that could really have an impact. I'd be really open to understanding that over the next year or having a slide that is similar to that in next year when you guys present this, just to kind of understand this is what we've learned in our touch points, and you guys can think of policies that can help us with that. Absolutely. So thank you for the good work you all do.
Thank you, Board Vice Chair Bushnell.
Thank you, Chair. Thank you so much for the presentation and everybody for all the work that you're doing. It's incredible. I know hearing the stories, it's very meaningful for so many. I'm just really shocked at seeing 82% of these deaths were preventable. And I also recognize that even with the program doing the great work it's doing, the data is really indicating that amongst our Black community, the line is pretty elevated and consistently over time. And then you mentioned it started back in 2009, kind of like as a initial start, but then now we're in 2026. Oh my gosh, the years. But there's still so much more to do. And I think the question you asked earlier about how do we make sure we're bringing equity into the system, I think the data really points to where the inequities are occurring in the system. And that's why I think having a Black Infant Health program within the department is so vital, because if we can make sure that we are supporting that population with the elevated levels that they are, I think it would help overall with everybody else. That being said, I'm curious. I heard a little bit. You guys have alluded to some of the partnerships that you've had out in the community. I'd love to hear a little bit more about that, because the health department certainly has a part of this. But I think for a systems-wide approach, we need to be having conversations with the healthcare providers. And could you talk a little bit more about maybe where the hospitals might fit in with the different clinics and how that might be able to help kind of move the needle in a better direction for, our whole community? And maybe that's partly why maybe we're seeing these outstanding numbers for Pierce County specifically. So just curious about that. Thank you.
I don't think I introduced myself for the record. Chantel Reed, Director of Tacoma-Pierce County Health Department. So some of where we are right now is really figuring out like how we get into the systems, because most of the successful programs that I've operated in this space before, for the record, you all know that I'm a doula. The best partnerships are when we start in the hospital system. We've spoken about cultural competency, but also cultural humility. In our community, the very diverse community that Pierce County is, it is people going into the hospital systems and understanding how we meet clinical with cultural. In a lot of our communities, it is, what are the practices that we see in these communities and what people know? What does breastfeeding look like? What happens in our communities when babies are delivered in a tribal community, in an Asian Pacific Islander, in a Black community? How do we approach those with partnership in hospital systems? What we've been doing is I have been meeting on the leadership level, on the administrative level. Dr. Miller has been meeting as well, because we have to start at that system level so that we can say, can we go in with our program and partner with those individuals to say, yes, we can meet with the mom, but if we show up in a hospital and say, oh, we want to bring this particular program, we don't know what the system is. We don't know. The providers are uncertain. We've been starting to have those conversations. It can be difficult because a provider goes in and they want to be able to approach things from a very clinical perspective. That is not an easy space because they want to be able to go in and say, we delivered a baby and we go. We have been making some inroads, but to your point, board member Sadalge, it is very, systematically, programmatically, legislatively, policy-based. It is a better approach for us to approach it in that perspective, so that we say a mother can have a doula, a community health worker, someone in that space that can support them in those areas. It is. When we look at our strategic plan, some of it has been broad because some of those things are softer skills, not always driven from metrics. We are looking at how we approach those in those areas. We're starting to see some improvements, but of course, there are ways that we can do better. And that's where we're hoping to see greater partnerships, greater developments, but more work to come in continuing times. I have had those conversations with leadership of the hospital systems, but we're going to continue to develop those relationships and looking for them to continue. But my hope is that we're directly embedded into the hospital systems so that when a mother has a baby, we're directly partnered with a mother so that we can support them.
Yeah, that's great to hear. Thank you.
Yeah, and I've done those. I've done both of those partnerships in my previous work.
Great. And that was my other question is we're certainly not the only ones experiencing this here in Pierce County. And what other ways that we can learn from others that might be doing similar work? And then also to our board member Stolige's point earlier, what can we do as a board to help convene, to help build those relationships, to help make sure this is a priority within our community?
Yeah, I've seen it done on a policy level. I've done it on a policy level perspective where it's an opt-out model rather an opt-in model. So we can build policy where if we see these rates so that when a mother delivers a baby here in Pierce County, if they are at risk, we can pair them with support systems, a community health worker, so that they go home and we can reduce our mortality rates for both mother and baby. I built that policy. I wrote it myself, so I know exactly how it goes. So those are some of the things that we could help with directly. I'd love to be able to bring that here to Pierce County.
Yeah, thank you so much. Yep. And then I don't need it right now, but I'm curious about the disaggregation of the data around the behavioral health related deaths and then also the other 55%. Just I'm just curious about it.
Yeah, we are working on that with our the dashboards that you all worked on last board meeting, I'll say. I think it's the last board meeting. But also Dr. Miller is here specifically on the infant mortality review and child death mortality review. We can get that to you, or Dr. Miller. I can have Dr. Miller come and speak a little bit more to that.
Great.
Yes.
Thank you so much.
Okay.
Thank you, Chair, and thank you again all for your work.
Thank you.
Thank you. I had a couple as well, but wanted to pop. Do you have a question? Go ahead.
All right, so one comment and one question. First of all, while I share some of my fellow board members' concerns about some of the disconcerting numbers, I just wanted to point out the 100% satisfaction of the 69 clients that would recommend BIH. That's a great Yelp review. I mean, that's an impressive number. So just wanted to say thanks or congratulations.
Yes.
Congratulations on that. I did have a question. I'm curious, would you describe what the Tacoma-Pierce County Health Department is doing as cutting edge for Black infant health, or is this routine? I mean, are there hundreds of health departments doing some sort of Black infant health? I'm just curious, are people reaching out to you trying to model and copy what we're doing here? I'm just curious.
I would say it's bifold. I think that some of the things that we're doing here from a community health worker perspective is somewhat cutting edge here in Washington State. But I will say that it is consistent with what's happening across the country. Right now, it is National Black Infant Health Week across the country. So all over, everyone is celebrating it, and they're doing some of these things across the board. But there are some things that we're doing here, specifically here in the department, that I'm most proud of. The folks here have taken up the mantle and have carved this specifically out and are doing some great things that are not necessarily happening across the country in the same way. So yes, we are doing some things that are not necessarily the same.
Good.
Yes, yeah.
Thank
Yeah.
you.
Thank you, Director Reed. I had two questions, and then many of my other questions were answered. One of them is around the 81% of the children graduated. What does it mean for the 19 that didn't graduate? I'm just curious, what does that mean?
Yeah, so sometimes we have clients who kind of fall off from life events, or, after the postpartum period is really stressful. So we tend to get a lot of engagement in pregnancy, and which is great. That's when we can give a lot of the education and everything. And then some folks moved out of county. That also happens. So I say most of that percentage is probably folks who either stopped engaging, we weren't able, whether it's their own stuff with phone issues, or they moved, kind of situational. But then we have a decent population who will transfer into King County or something. And
Okay, thank you. I was just curious what that
Mhm.
I want to acknowledge on Emily's side the integrity of the program. So the program is for children up to age 1. They don't get credit if the child ages out after age 1. So that's also a consideration as well. So I want to acknowledge that too.
Okay, thank you. The second question is around, I guess, your role in the community health workers. One of the things that, and this is completely anecdotal, I have not experienced this, white woman, where there's bias and racism when you go and talk to your doctor. Do you help coach, support, advocate, show up appointments? Is that part of the work to try and dismantle that so that people are getting the care they need?
Yeah, 100%. Yeah. Our community health workers and nurses are really strong advocates for our clients, and can often accompany to appointments. But a big part of our work that we do with families is kind of educating around that, and the need for self-advocacy, and that it's okay to do that, and kind of coaching around how to do that. And we also all of our community health workers are trained in how to file grievances with hospitals if there is a situation that occurs. So,
Okay. So going back to that question that you asked us, if we didn't have to have people trained to do that, we would have a more equitable system because you'd be getting the care at the beginning. My last question is around some of our partners. Immediately when you were talking, the Black Collective and our Sisters House are great allies. And I just, my assumption is they are aware of this program and have like the ability to refer, like, here's who you call, but I just wanted to check and make sure.
Yes,
Okay.
yeah. We just had an event for clients last night, and our sister's house was there to share their resources too.
Okay.
Yes.
Takes a village. So, okay.
Yeah.
Not seeing any other questions. We did kind of jump to questions. I don't know if you were actually done after that
Oh,
last
yeah, I was.
slide.
The last
so-
slide was just question.
Okay. So, thank you so much for the work you're doing. And then I just want to highlight, Board Member Yambe brought it up, but we did proclaim, and City of Tacoma did as well, that it's Black Wellness Week. There's an event happening that's free, community-based. It's open to everyone, but with a focus on our Black community members. It's going to be from 12 to 3 on Friday, this Friday, at the People Center on MLK. They're offering some free health screenings. You don't need to have insurance. And they just also have a lot of resources. I'm hoping maybe this organization will be there, and just really trying to highlight just that we are trying to provide for a population that is not getting the care they need. The data shows it, so appreciate that you're going to be there.
Thank you. Thank you all.
Okay. So our second item on our agenda this afternoon is an update on business support services. We're going to turn this over to Director Reed.
Okay. Good afternoon again. Chantel Harmon Reed. For the record, I'm the director of Tacoma-Pierce County Health Department. So today I am going to go over the business support services update and give you a little bit of background about what we have going on as I have assumed the role of the interim finance director. Next slide. So today I'll talk a little bit about who we are and what we do, go over the current workflow and challenges, talk about the improvement plan and next steps, and then give you an opportunity to ask any questions and have a little bit of a discussion. Next slide. So our tie to the strategic plan is to really, as I walked in the door here, I really wanted to focus on efficiency and effectiveness of department operations. The first things that I noticed was our contracting process and really focusing on how do we move through the whole revenue cycle process and how do we get from contracting to provider payments and the like, and informing us on how we do forecasting and all. So we needed to improve and streamline our contracting process. We want to make sure that we proven systems so we could better track our spending, allow for scalable and stable operations to meet business requests. We, of course, want to complete 100 process improvement plans by 2029, and then reduce backlogs when permitting, requisitions, contracting by 20% in 2029. To your point, Exec Mello, these are some of the easier ones that we can quantify. There are some opportunities for us to improve all the way across the board. We're still refining. There's opportunities for us to continue to refine, but in, of course, some of the finance areas, it's a lot easier for us to add some quantified or SMART goals. Next slide. So business services and what are the functions of those areas? Next slide. This particular area of the department manages our money, quite simply, how it's collected, allocated, spent, and reported on. This includes accounting and reporting, all of our billing, budgeting, planning, compliance, debt and cash management, the financial analysis, contracting, revenue management, policy support, and then overall payroll spending and oversight. Every single thing that comes through from a fiscal management perspective is managed in business support services. We have centralized everything here into this department. We had some, I'll say, delegation within the divisions, but we understand now that making sure that all of the functions are managed in a very centralized manner so that we understand, contracts are not managed through division directors. It's managed in this one area of the department, so there's standardization of processes. So you're not doing this one way, folks over here are doing this another way. We are very clear on the processes, and we know that it is maintained in a place where everyone knows what's going on and it's not all over the place. Next slide. There are 4 programs in BSS. It is accounting, of course. So this is where all of the invoices are processed, all of those things that are actual real-time functions are happening. The fiscal and budget. So this is the forecasting of revenue coming in the door and planning on how we're going to spend the actual money. Our MAC program, the Medicaid Administrative Claims Program or Title 19 program, that funding that we receive from the Healthcare Authority, and then procurements, like how do we secure goods and services through the department. Next slide. So the composition of the BSS leadership team is myself right now, currently as the interim finance director, accounting manager, Sue Yee, fiscal and budget manager, Jamie Paulson, whom you've seen presenting our budget several times, the MAC manager, Kathy Mortel, and then procurement, Nathan Mosley. Right now, for director level oversight, it's being provided by Sinajitsi and Jody Dyer. I have this in place to make sure that we have a check and balance so that I'm not signing as the director and the finance director. This is for contracts so that I'm not signing in 2 lines. So I'm not signing as the director and the finance director. Cindy or Jody are providing this oversight so that when contracts come through, we make sure that I have a check and balance. Sue is also overseeing these contracts so that we have multi-level signatures as it's navigating through and passing through the contract process. Next slide. So the current workflow and challenges. Next slide. So right now we have a very complex multi-step access to the software with very unstable connections. We have a dual system. Right now it's called New World. There's also a system that we have to go through called eSuite. You have to log in through VPN. There's also a complex login that you have to make sure that either you're on site or on this VPN, and then another check that you have to log in to. The system, I think currently, last year we were saying that it was 14 years old. I think right now it's about 15 years old. Very dated software that we're navigating through. So we're trying to figure out how, one, do we manage this system to its maximum capacity, and then figure out how do we get reporting to, I'll say, current standards and expectations. We're also trying to figure out how we export information so that we can give real-time information to division leadership and understand like how they can make decisions based on information that they have to be able to support changes in funding, changes in spending, changes in accessibility of funds. And then we also have other systems that are navigating throughout the department, whether it is fee-based revenue or we have like Vital Records has their fees that come through, food as well as environmental health has several different systems, but none of them all communicate through each other. So we are trying to make an understanding or have an understanding of how we navigate through those very complex systems and complex interoperabilities to make sure that we are maintaining the system as best as possible. Next slide. What we've also discovered is there has been, past tense, a lack of internal controls. So as I mentioned, when I assumed the interim finance director role, there was a multiple level instance of several layers of signatures where one person would sign, another person would sign, and that was it. We have since amended this process to make sure that there are several layers of checks and balances to make sure that human resources, finance, operations, and executive leadership makes certain that we are accountable to our finances, our funding sources, and of course to the board. We have made that improvement. It was a very quick process. I believe we put into place with Laserfiche through signatures and then through the PAR systems process. We made that change very quickly. We went through a quality assurance review, made sure that it's timely and that it's not a cumbersome process so that we are all clear and have an expectation of how we can be responsive and accountable to the funds and fiduciary responsibility of the health department funds. We also had responsibility to implement the recommendations for the state and independent audit controls. Those also were implemented, and I believe that we've reported those to the Finance Advisory Committee, as well as to the Board of Health through subsequent changes that we made at the last Board of Health meeting. And a lack of real-time data. So what we discovered is there was a high dependence on the budget process rather than actual financials. One of the things that I discovered was that we were not receiving a month-end reporting. So how do we spend our money? Like, where are we? Are we up to date? Or like, how are we on either overspend or underspend on revenue? So is a grant going to be overspend? Is a grant going to be underspend? We were not receiving that information. So what we've put in is a month-end close, real basic, that's necessary for us in decision making to make sure that we're not getting to the end of a budget cycle or a grant close and having too many funds that we are spending. We also want to make sure that we're not spending, I'll say, revenue on things that are not fiscally responsible. We want to make sure that we can do hiring appropriately. We can make sure that we are securing resources appropriately. Some of the things, for example, are capital expenditures. We wanted to make sure that we are budgeting appropriately for capital expenditures. So in this review, in a very short time that we've started through this process, we are able to start the planning for long-term, not only just for, future buildings, even for the building that we're in. As you look at this brick right here, there are some necessary things that we need to do just even to remain in this particular building that we need to plan for. And what we don't want to do is take those funds out of our current operating budget. Any funds that we take out of our current operating budget is money that we take from programs like the Black Infant Health. I want to make sure that we are consistent and we are very clear in making sure that the funding that is extrapolated out of any necessary resources are prudent. So we are making sure that it's real time, it is accessible, and we are making sure that division directors are clear on how they allocate funding appropriately. So we have changed our approach to a much more proactive approach rather than reactionary. So it's really made a difference in how division directors are responsive to staff and are doing appropriate either hiring or preventative in layoffs, especially for future perspectives. Next slide. And then process improvements and progress. So as I mentioned on the contracting side, centralizing information and making sure that procurements are appropriate, that we're clear on what grant timelines are. There are a lot of rolling timelines from grants perspectives as far as fundings that we receive from either federal, state, or local funding. What we don't want to happen is to continue that we are waiting until the last minute to expend grant funds. We want to make sure that there are no underspends as well as not any over expenditures. So we've streamlined the grant process. We made sure that there are briefings, not only for myself, but also for the leadership team. So if we're coming close to a grant period, we determining that there's going to be an underspend, we are very clear on making sure that funds are either delineated or reallocated as appropriate. And then we're making sure that we update the procurement documentation so that there is not any cause for clawbacks, there's not any cause for us to be non-compliant with any of our funding. And then making sure that all staff are trained on the processes. So we're making sure that we develop programming so that they're clear on what needs to be done so that they can be compliant as well and are clear on the processes. Next slide. And then the grant process. So this also was a process that we needed to make sure that we provided some greater clarity on. Oftentimes we apply for grants, but then we're not certain on how we manage them in the long term. We needed to make sure that we were monitoring them appropriately, that we were making sure that we were compliant in them, and then everyone understood what their role was. We needed to make sure that any support functions also were included. So if that was communications, if it was AEE, if that was finance, whomever needed to be involved in the process was very clear early on, and that what their roles and responsibility were included as a part of that granting process. We also wanted to make sure that the dashboards were included. So as we're looking at how, like, even from the strategic planning process, not just from the funding perspective, but also like what are the deliverables of the grant, and are we meeting the deliverables the entire time of the grant? So we're not saying like, oh, we need to service 100 people and then we've only met 10, 12, 20, 30, whatever it's supposed to be. We're making sure that we hit the benchmarks throughout the entire time. So that way also that we're not in a place of non-compliance throughout a grant. So those things are happening across the board as well. We know that any non-compliance with a grant, even though that it may not be fiscally attached, it could, if we're non-compliant, could result in a clawback as well. Next slide. And then additional improvements include tracking the expenditures real time. So what we had been doing was, as I mentioned, where we're now doing the month end close. We also were not doing month end close until the end of the year. So we did not know until the end of the year whether or not we were spending funds appropriately in a grant. We are now understanding real time invoices are charged to a grant at the right time, and making sure that the programs understand what they're spending in a grant so that they can keep track of those things, so that they're on time. We're also making sure that the quality improvements, like I mentioned, making sure that they're hitting the benchmarks clear and that they have the dashboard so that they're compliant as well. And then modernizing the agent software and the systems. We're not certain of what this looks like, but we are certain that a 15-year-old financial system is not going to sustain much longer. So we are going to have to do the work in order to research what it might look like in the coming years. We are chugging along right now, but we are going to have to figure out, like, how do we do a transition into a new financial software system. So once we have a clear understanding of what our true needs are, what is out there for an agency of our size, then we'll be coming to the board aptly and asking you for your feedback on how to support us in transitioning into a new financial system. And then the next steps, more immediate, are hiring a finance director. That position has been posted. We do have some applicants that are out there. We are asking some members of the Finance Advisory Committee to participate with us in the hiring process. We're also going to be potentially engaging with a financial consultant to support us in the meantime until a full-time finance director is hired. And then we're going to be continuing the process improvement processes with accounting and budgeting, and then reconvening stakeholders as needed. I will be continuing to come to the Finance Advisory Committee so that you all are aware of our status, and then any pertinent information that we need to be sharing to make sure that you're abreast and aware of movements and changes of the organization, of the agency's financial health status. And that's what I have. So opening it up for any questions that you all have.
Thank you, Director Reed. Appreciate your thoughtful presentation and overview of this after the last Board of Health meeting request. Looking to my colleagues to see if there were questions. People are like looking back on slides, so I think you're looking for questions.
Yeah,
Vice Chair.
thank you, Chair, and thank you, Director Reed, for this presentation. One of the responsibilities of the Board of Health is to make sure that our finances in order, and I know that our finance department works really hard to make sure that's the case. And there's always opportunity and room for improvement. And I think you've identified multiple areas of improvement. Could you kind of walk me through a little bit more about month-end close? I kept hearing that. And I just want to understand that in the context of our budget and how that's so important. Additionally, I obviously try to get near real-time understanding of where money's going in and out, but are there other implications for that?
Yes. So every organization, agency needs to close out the books at the end of the month so that we know how much money we've spent. Um, Historically here, we've only closed the books out at the end of the year. That puts us at a disadvantage because we don't know at any given time, like, well, are we over? Are we under? Where do we stand at any given time? What happens is, or what has happened historically, especially when I came aboard initially, was, well, we're significantly underspent. It doesn't allow us time to be able to reallocate funds to other areas where in other places we're significantly overspent. And if we're overspent, then I can't move monies around to be able to recover where we are underspent. We're going to lose that money over here. And then we're overspent and we have to pull monies from either reserves or in monies that we might have otherwise used for capital expenditures or some other places. We aren't able to pivot if we're not closing and understanding what is our financial status at the end of every month. What I like to do is at the end of every quarter, have an understanding of where we stand fiscally and then be able to reallocate. But then I want to be able to know so that I can say, oh, well, yes, we can either do some additional hires or some additional planning or additional reallocations. It just gives me a greater stability. It gives the agency a greater stability.
An opportunity to be nimble with
Mhm.
with the different allocations and things of that nature.
Yes. Yes.
Thank you for that. And then I think I have more questions, but I'll save it for other folks. Thank you.
Mhm.
Thank you. Board Member Sadalke.
I've, I noticed something here on slide 10. It had need to implement recommendations from state and independent audits. Was there color in this weekend? Is it just around financial controls?
So, in
Because
some,
it's the state that audits us,
Mhm.
right? Okay.
Yes.
As a municipal kind of entity.
So the state has they performed their audit, and when they did their last, I'll say probably 2 audits, it is how we have done some journal entries and how we do our practices that they made recommendations for corrections.
Got it.
There are the material findings, and then there are significant corrections. Material findings are major. Significant corrections are not as major.
They're operational.
Right, they're operational. We had significant corrections that we needed to correct, and those are the things that they found that are operational on how we record some transactions that we needed to correct. We did make those corrections. There was one that we made, but I believe we made it again this year, and we needed to correct how we make those journal entries in our finances. We made those corrections and we've changed our policies and how we record those in the general ledger this year. Those are the things that we wanted to make sure that our policies were changed and how we record those. One of the things that we found is how we record things on our budget, because how it's recorded in the budget is how we have to record it in the accounting. It's really a change that we had to do some education and corrections on. We made the correction. We're in a better understanding. And now that we're in that place, then now we can record things in a different way.
And to that point, one of the questions, I mean, I have a background in finance, just
Right.
so people understand.
Right.
started
I know you know. I just explained it so that way everyone else could understand. Yeah.
No, absolutely.
Yeah. Mhm.
Budget versus actual, is that also kind of a review that is done regularly or just annually right now?
So it had not been done regularly. We are still not at a
That's
place.
something we should expect to be able to see maybe on a quarterly or biannual basis?
Yeah, we're still not at that place where we can do that. But now that I have taken over as the interim finance director, you are gonna see it quarterly. Just because we need to have an understanding, like I mentioned, if we need to pivot, if we need to do reallocations for either underspending or overspending, I have to know. I also believe very strongly that I need to be able to report that to the Finance Advisory Committee so that you all have an understanding what our financial health is. So you're going to have that information as soon as we start some of the corrections that the state auditors have recommended in our policies so that you have an understanding of what we're doing.
So the expectation is after the end of this to have some regular cadence of budget versus actual with some variance explanations
Yes.
that are provided with materially large things. So we kind of understand the near term kind of, the near term kind of pressures that we might be seeing. Got it. Last thing, two things. I mean, I support all this. The flexibility is absolutely essential, especially in a world where we need to have it really, we need I's dotted and T's crossed in a world where we have, let's be diplomatic about this, I suppose, a changing funding landscape coming from our state and federal partners, which are a large portion of our operations. The last question that I'm going to have is just based on my experience in private industry. We've eventually needed to implement a contract management system of some sort to kind of understand the various contracts that are out there, basically to understand what have we signed up for financially, right? In all these contracts. Do we have one, or are we considering one as a future kind of step for grants, for example?
Oh, I'm glad you asked because yes, we started that process. So we centralized. So the procurements team that I mentioned to you, that is what we've started. So we centralized that because before each division was managing their revenue and their expenditure contracts. And that gave me so much anxiety because what we were seeing was we were receiving checks randomly, checks, because divisions were doing their revenue contracts and we had no idea where to charge them to. We have centralized that so that we have an understanding and a central repository of where all contracts come from. And we understood like where, and then we could refer to legal so that they could do a review. They could do a review that we have an understanding of what our fiduciary responsibility was in every single instance of every contract. One example is like the ILAs were not going to the board, but the way it is written for state statute was that all ILAs need to go before the board. That was a change. So it's those types of things that we have centralized and is going through that contract management review. We're still cleaning it up. We're still finding some things that is like, oh, we didn't know. And we're bringing it to that centralized group management or contracts management. We also have grants management that is working in conjunction with the contracts management, and that's also centralized too.
Thank you for all that color. Thank you. Appreciate it.
Thank you. Any other questions? Did you have additional ones, Vice Chair Tease, that you might?
No, I think Board Member Sadalge really got to it. I was curious about the contracts and to hear that receiving checks and not knowing where it needs to go to, that it's not very clear. Thank you.
Thank you. Board Member Mello.
Thank you, Chair. Thanks for the briefing. Thank you for how seriously we're taking the process improvements. When do you think we can realistically expect to begin receiving quarterly budget reviews with the board and you and the finance team?
My hope is for third quarter of this year. We are rapidly making some changes and rapidly making some improvements. I was very happy to hear that we have gotten a significant number of applicants for the finance director. So as soon as we can implement that and then start like delving into the finances and going through, I feel optimistic that hopefully by third quarter, because I need to be prepared for the fall amendment. And once we're ready for the fall amendment, then I want to have a certainty of having an understanding of where we are on actuals, because my plan is to have actuals.
Thank you.
Thank you. I'm not seeing any additional questions. So again, thank you for bringing this back after the conversation that we had
Mhm.
2 weeks ago. And appreciate the level of detail and the team and all the work that's going in here. So thank you.
Thank you.
We do not have an executive session today. We just always put it on there in case we need one, but we always hope we don't. So is there any other business or announcements? Not seeing any, so I'll just, again, it's Black Wellness Week, so please, if you can attend that event. If not, please spread the word about the great work that's happening at the health department to reduce the deaths of Black women and children. It's something we should all care about. So thank you. We are adjourned.